Hey everybody, welcome back. Today I have guest Dr. Padia, who is here. He's an interventional radiologist at UCLA from California. And today we're going to be chatting about liver-directed therapies for metastatic disease with some exciting updates about Hepzato Kit. So thanks so much for joining me, Dr. Padia.
Thanks, Nate. Thanks for the invitation. Glad to talk about this super exciting topic.
It's super exciting, and it's such an important thing for us as patients. If you're dealing with metastatic disease, if you're potentially going to be dealing with it in the future, or you're worried about that, it can help a lot to get this information and to just have a better understanding of what's out there so that when or if the need arises, you're not just trying to scramble for information. You now have a knowledge base. You know kind of where to go and you know what to do. So, Dr. Padia, can you just help me define Hepzato Kit? What is it and how does it work?
So great question. Just to step back, one step back, I'm an interventional radiologist, and what most interventional radiologists do is we use imaging guidance to do minimally invasive procedures, and that's most often things in the blood vessels in your arteries and veins. The Hepzato Kit or the Hepzato procedure is a procedure that is done through the arteries and veins, specifically in your liver, and this device and procedure is designed for people who have uveal melanoma where the uveal melanoma has metastasized to their liver. The procedure itself has become commercially available in the United States in 2024. It was FDA approved in 2023. And the reason it was FDA approved was there was a clinical trial done in multiple centers, both in the United States and in Europe, where they did this procedure and they compared it to what is considered the best available care. And so at every institution that might be different. It might be immunotherapy, it might be chemotherapy, it might be something else. And so they compared it to that and they found a significantly higher outcome. And that's in two respects. Number one, it shrunk tumors to a much higher degree compared to the patients who received, let's say, standard immunotherapy. And number two, it prolonged survival, which is, I think, probably the most important thing. And number three, which I think is equally as important, is it preserved people's quality of life. So in other words, the side effects and the complication rate was pretty minimal and manageable, where most people can kind of go on their daily lives. And that's what we've seen in our experience. So what is the Hepzato Kit? It's a device that's used in a procedure. The procedure is done in the hospital. Currently, there are about 7 to 10 centers in the United States, and I think that number is probably growing over the next several months as certain centers kind of come online. So few centers currently doing this. As you can imagine, we tend to get a lot of people coming in from outside of the Los Angeles area. In fact, I would say half the patients that I've treated have been from outside of Los Angeles County. The procedure is done in the hospital. It's done under anesthesia, so we have an anesthesiologist who puts you to sleep just like any other surgery. And then what we do is we isolate the liver via the blood vessels. That's done two ways. So the way blood flow works in the liver and in, let's say, every organ, you have an artery that takes blood from the heart to the liver, and you have a vein that takes blood from the liver back to the heart. Okay, so and that concept works for every single organ. So if we're in the brain, you have an artery that goes to the brain from the heart, and then you have a vein that goes from the brain back to the heart. So that's how we do our circulation. Your liver, your brain, your toes, your fingers, etc. The goal is to isolate them. What's that?
I just said all the parts.
All the parts. So arteries carry blood from the heart, veins carry blood back to the heart. And so the goal when we do this procedure, which is known as percutaneous hepatic perfusion with melphalan, also known as Hepzato Kit, is to isolate both the artery and the vein in the liver. And so where we're giving very high doses of chemotherapy, the name of the chemotherapy is melphalan. It's actually quite an old chemotherapy. But the challenge is that when we give this chemotherapy, let's say through an IV in your hand, it goes whole body, and there's only so much of a dose that your whole body can tolerate. That dose of that chemotherapy is not effective for your liver. And so by isolating the liver and delivering it directly into the artery that goes into your liver, and then sucking the chemo out via the vein so it does not circulate throughout your whole entire body, we can give much higher, 5 to 10 times the dose. because almost all of it stays within the liver or is trapped outside of it. Very little of it circulates throughout the rest of the body. So how does this, let's take one more step back. How does this work? Okay, so you're put under anesthesia in the hospital in our interventional radiology suite. All of this is done through tiny little skin nicks. So at the end, you just have Band-Aids. There's no big stitches or sutures or anything like that. We have one tiny little catheter. It's the width of maybe like the tip of a pen. It goes in the upper left thigh. That catheter goes through the arteries all the way into the artery going into your liver. That is called the hepatic artery. We then have another catheter in the right side, in the right vein in your upper thigh, that goes straight up into what's called the inferior vena cava, which is the blood vessel that drains the veins from the liver. So now we have a catheter in the veins from the liver, we have a catheter in the arteries going to the liver, and we infuse the melphalan, or the chemotherapy, through the catheter in the liver artery, or the hepatic artery. At the same time, we remove the blood from the vein of the liver. So what it does is it washes through the liver, similar to if you were putting like a sponge under your kitchen sink, running the faucet. The water will come down into the sponge, and then it'll kind of come out the bottom of the sponge as it percolates through the sponge. The chemo does the same thing, but instead of leaving and returning back into the heart, we suck it out through that catheter. We put it through a filtration circuit to extract all the chemo, and we return the blood back into another catheter into the patient. So it's essentially a closed circuit where we filter out all the chemo. The procedure itself takes about 2.5 to 4 hours. It's done under anesthesia, so you don't really feel any pain. And at the end, we remove all these catheters and we put 3 or 4 Band-Aids on. The recovery is, you recover from anesthesia, and in our practice, we've been sending patients home either at the end of the day or the next morning. And it takes about 3 to 4 days for you to there's 3 or 4 days where you're feeling a little bit of fatigue, but most of the patients we've treated have gone back to work either by the end of the week or early next week.
This sounds awesome. I don't know about you guys. I know that the more that I understand about this procedure, the more excited I am that it's available and that it's, like you said, it's FDA approved here in the United States. And I think we'll probably allude to this a little bit later, but it's also approved for use in Europe.
It's been approved for several countries in Europe, including the United Kingdom, Germany, Netherlands. Those are probably the 3 main countries, and they've been doing it for some time now. There are centers in Europe that have done, in fact, probably a few hundred by now. And it is nice that it is FDA approved in the United States because of the data. That also means that insurance carriers routinely cover this now, even though it is new. It was a little bit, I would say, rocky in the start because they never even heard of this. But now I would say that most insurance carriers have, if not all of them, have put this into their policies. It is designed for people with liver metastases. So it's not, if you have uveal melanoma and it's spread all over in the lungs or in the lymph nodes, it's not going to do that. It's not going to really be effective for that. So the key thing to keep in mind is that it's really addressing people where either all or at least most of your tumors have metastasized to the liver.
Just for any of us who are visual learners, do you have maybe a video or a short kind of a picture that we can show this closed circuit? Because I think that's one of the most unique things is this. I think I've heard it compared to almost like putting the liver on bypass. I think that's maybe a good way to describe it. Do you?
That's absolutely right. And I'm going to try to share my other screen here.
Awesome. All right. So let's talk through kind of the visual and what do some of these kind of images mean in real life? Because this looks like an actual image of the liver or the veins.
So these are X-rays. And it's actually almost the same X-ray. One is just what's called digitally subtracted. So that one on the left, where it's almost all white with some black in the middle, that's digitally subtracted. So let's go on the right side of the image. You see these 2 circles, right? And it's connected with this big, thick line. So that's the catheter. That catheter is inserted in the upper right thigh in your vein, and it goes all the way up into a blood vessel called the IVC. We inflate these 2 balloons, which you see this big circle on the top of the image, and this oval on the bottom of the image. And so what that does is when we inflate those 2 balloons, it isolates that segment of the vein that's in between those two balloons. That segment of the vein is what drains the veins in the liver. So the veins in the liver, which is on the left side of the image and the right side of your body, because we look at everything in kind of in portrait mode, drains into the region that is isolated between the two balloons. Now, if you look at that bottom balloon, there's this horizontal wavy line. It's like and that's the catheter. It's another catheter. That catheter is the width of the tip of a pen. That catheter comes from the left leg, so it comes all the way from the bottom of the image and then kind of courses to the right upper quadrant of the patient, in this case the left side of the image, and that is in the hepatic artery. So where your mouse cursor is, that's the tip of the catheter, and that at the back end outside the patient is connected to the chemo. It's infused into the liver, and it is then withdrawn through the two balloons. So on the left image where you see that black stuff, that's us injecting contrast dye. So that thick column of black, that is the IVC, and then those streaks going to the left side of the image, those are the veins from the liver. So you can see everything is isolated. So it's basically withdrawing all that contrast, which is blood, outside of the body, filters the chemo out, and then re-infuses it into a different catheter into the veins. So that's in summary of what we're doing here. Now this is that, remember that wavy catheter we had in the hepatic artery? So this is just an isolated picture of that. The black stuff is contrast dye. So what we do is before we infuse the chemo, we inject contrast dye, and that lights up as black. And what happens is we digitally subtract out the background, which is why everything looks faded out or white. And all these squiggly black lines, those are the arteries in your liver. And in this case, it is the right hepatic lobe, the right side of the liver. And those big blotchy gray things, those are tumors in the liver. Okay, so what we're going to do is we inject the contrast dye, make sure we're in a good spot, in this case, the right side of the liver. And then we switch the contrast dye for the chemo. The chemo you can't see on the screen, and then the chemo infuses into these black lines, these arteries, into the tumors themselves. And again, this is, when we're doing this, the balloons are inflated in the vein, withdrawing the blood at the same time.
It's so incredible what medicine can do and how advanced this is.
Not only that, if you think about like the resolution, this is obviously magnified up. This catheter is about 3 or 4 thousandths of an inch in diameter. So that artery is super small. It's like an eighth of an inch in width. And so those distal arteries, the ones downstream, they're basically the size of, the human hair.
That's incredible. So we have covered a lot of really neat stuff. Is there anything that, for anyone who does have liver metastases, just as far as kind of qualifications, like for a good candidate for Hepzato Kit, what are some of kind of the baseline markers, aside from obviously liver mets, that you guys are looking for as far as the patient health and all of that?
Yeah, so that's a great question. So, of course, you have to have liver metastases, ideally really no significant tumors outside the liver, although we have treated patients who have predominantly liver metastases, because it is widely believed amongst most medical oncologists that once you develop liver metastases, that is the leading edge of the problem, even if you have, let's say, lung metastases or lymph nodes. There are several other different types of liver-directed therapies that we can perform in the liver, and all of them have their advantages and disadvantages. So when I see a patient in consultation, let's say for this, I look at them, look at what they want or what they have in mind. I look at their liver on their imaging, typically an MRI, to figure out how many tumors they have, where the distribution of the tumors are, and then I kind of make recommendations as to, okay, you have option A, B, and C in terms of your treatment options for your liver. These are the pros and cons of each. So, for example, most people for Hepzato, this is meant as a whole liver treatment. Okay, so we don't normally just treat one side of the liver. So most people should have multiple hepatic metastases in both sides of the liver, let's say left and right. In contrast, if you had, let's say, one tumor just on the left side, I would recommend some other procedure, for example, a ablation procedure or a Y90 radioembolization procedure. Those are really more designed for focal treatments within the liver. The great thing about Hepzato is that it is designed for a whole liver treatment. Okay. Additionally, there are certain other qualifications that one must have. Since you are undergoing general anesthesia, we want to make sure that people can tolerate that. And so what are the main risk factors for general anesthesia? Anyone who's had a heart attack, coronary artery disease, congestive heart failure, those people would be at relatively high risk for general anesthesia and would probably not be candidates. Additionally, since you are put to sleep with anesthesia, we want to make sure people don't have any breathing or lung problems. The most common things are like emphysema or COPD. And also, since we are putting people on blood thinners simply during the procedure, not afterwards or beforehand, we want to make sure that they can tolerate blood thinners. So, for example, people who have had prior bleeding episodes may not be a candidate, or people who have metastases in their brain may not be a candidate. So we have basically what we do is when we see someone in consultation, we have a checklist and we kind of go through the checklist to make sure that they are candidates. I would say, at least in our practice, there's a good proportion of patients who are candidates for the Hepzato procedure. And there's also a lot of patients who are better candidates for an ablation procedure or a Y90 radioembolization procedure as well.
Okay, so let's kind of do a little bit of a role play here. So you're an interventional radiologist. I'm a metastatic patient who, let's just pretend I've just learned that I've got liver mets. And I unfortunately, and I'm going to just kind of pull from some prior experience because I've actually talked to quite a few of you guys in the OMI community this week alone. And it's been kind of incredible to me. And I think it's just one of those, the more things you're aware of, or when you say you want to buy a blue car and then suddenly you're seeing blue cars everywhere. Well, I'm a young patient with metastatic disease, and so I'm constantly aware of the younger patients like me who are also being diagnosed. Not to say that we are the largest percentage of the metastatic community, but it feels that way sometimes when I have, 6, 7 patients who message me in a week. So let's just pretend I just got MRI results on Friday and I'm consulting you because I've got like one tumor up here in my liver and one kind of down here, and the imaging and all of the things are pointing to I need liver-directed therapy, and I've heard about Hepzato Kit. Can you tell me why or why not would Hepzato Kit be a good option for me?
Okay, great question. So let's say you have that scenario where you have 2 small tumors, one up here, one down there, and it's decided that you want to pursue liver-directed therapy. And the first thing we do is we always get in touch with your medical oncologist, and we make this kind of a joint decision that is this the right approach for you. Just to take one step back, in general, any liver-directed therapy we perform can be done at the same time that you are getting systemic therapy if you are on systemic therapy. So, for example, if you are on a medication called tebentafusp, also known as Kimtrex, if you're on an immunotherapy agent such as nivolumab and ipilimumab, those are just examples and 2 of the more common ones, we don't even need to discontinue that. We can do it exactly at the same time. There's no interaction that we are aware of. So for someone with 2 small liver metastases, the goal is to do focal treatments of those 2. And the reason is, why put your liver, your entire liver, through a procedure when we can just knock off those 2 tiny lesions? So it depends on the size and the location, but the more common things that we would recommend in those cases is either, number 1, a thermal ablation, or number 2, a Y90 radioembolization. So what is each one? A thermal ablation is where we bring you into a hospital. It's an outpatient procedure. We put you to sleep under anesthesia. We take a tiny, thin needle, similar to the needle that you may have had during a biopsy procedure, numb up your skin using an ultrasound and a CT scan. We guide it into your tumor. So we're cheating the whole way through. So we know exactly where we're going, so we know not to go through dangerous things. At the end of that needle, there's an electrical cord connected to a generator box. We flick the switch. The tip of the needle heats up to about 150 to 180 degrees. We literally cook the tumor for 10 to 15 minutes, turn the switch off, take the needle out, put a Band-Aid on you, send you home. That works extraordinarily well It is designed for small tumors, just like, you have a shish kebab on your barbecue at home. The heat will start to dissipate the farther you go away from the heat. So I can't do a large tumor because of that, because then the heat won't reach all the way to the margin. It also has to be done in a tumor that is in a favorable location. In other words, I have to be able to get from the skin all the way into the tumor safely without damaging any surrounding structures which may be sensitive to heat. So a lot of people are candidates for that. Some people are not. And if you're not a candidate, then we would kind of, for safety reasons, or let's just say you're in a tenuous location where I don't want to deliver heat because there's the colon in the way, for example, then we would switch to the next treatment, which is a Y90 radioembolization.
Okay. Are there, and I know like this is maybe just me because I'm a little more aware of it and it's kind of a buzzword now that is being talked about in liver-directed therapies, but for like one or two small spots, has your interventional radiology team had any contact with anyone who's done histotripsy as an ablation option? And when do you think that would be best, in your opinion?
So histotripsy also just came out probably in the last year. Histotripsy is a relatively new method of ablation. So what we've typically done is something called thermal ablation, thermal meaning temperature. We heat the tissue, or in some cases, some people will freeze the tissue. Histotripsy is done by ultrasound waves, so there's no heat or cold. So the nice thing is, remember I mentioned that structures may be damaged by heat. Histotripsy doesn't have that issue because there's no heat delivered. So that's the great advantage of histotripsy, in that the damage to surrounding structures is essentially not there. Now, there are some challenges of histotripsy. Number one, when it was studied and when the trials came out, it wasn't studied specifically in uveal melanoma metastases. They did it in all comers. So people with primary liver cancer, people with metastases from colorectal cancer or breast cancer or melanoma. So it wasn't they didn't do a trial specifically for uveal melanoma. Number two, you also have to be able to technically get to the lesion via histotripsy. And there are a lot of places in the liver where the histotripsy device in its current version doesn't work or will not see the lesion. So it has to be approachable via the histotripsy device. But I think it's a great option for small tumors where the ablation, our typical ablation modalities, such as microwave ablation or radiofrequency ablation or cryoablation, are, let's say, high risk.
You're telling me that I have a couple spots and that we should do spot treatment essentially, but why wouldn't I want to just do the whole treatment? Like, why wouldn't I want to have my entire liver just dosed and get it over with, make sure that anything tiny, can't come back? What's maybe the harm of that?
So what we're trying to do, and this is something I think that we've learned in the last 10 years. What we want to do is design these therapies as a marathon and not a sprint. So what does that mean? That means that, let's say you come into my office for those two tiny lesions. It's, August 2024. I want to design treatments for you for the next several years. What I don't want to do is design a treatment for you for August and September and October of 2024. And then if you pop up new tumors 6 months later or a year later, I tell you, I don't have, all of our tools are kind of used up. And so this becomes, we want to stretch things out so you can live as long as possible with complete preservation in terms of quality of life. So today you might have two lesions and we can get rid of those. And in many patients, we've done that and we just monitor them with an MRI every 3 months and they don't ever pop up new ones, at least for several years. And in others, they may pop up a bunch of new ones. And then what we do is we start all over. We say, okay, what is your best option at that point? Okay. If we're careful and selective and preserve the rest of the liver, we can repeat these treatments over and over and over again, as long as you tolerated them, so we can get the most amount of longevity for you, again, while preserving your quality of life. The goal is to, if you're working a job, I want you to keep on working. If you're, like to go fishing, I want you to keep on going fishing. The goal is not to put you in bed all day.
Really, in general, when you're doing any liver-directed therapy, I think what you told me before was you want to treat the cancer, of course, like that's number one goal. And then it sounds like patient longevity is number two goal. And then that also kind of encompasses that high quality of life for as long as possible. Like those three kind of main things. So having the entire liver treated isn't necessarily going to be the most ideal because, like you said, it's going to almost use it too early in the marathon, so to speak.
Exactly. So let's say you did come in and I did decide to do a Hepzato procedure, which is fine and would probably work in someone with that low of a tumor burden. And then you came to me a year later and you sprouted a bunch of new tumors. So then I got a problem because I've already used up my main tool, which is the Hepzato. I can't necessarily go back and do ablation if, let's say, you sprouted up 10 tumors. And so we may have used up that option when I could have used something else.
Yeah.
And so that's where we're trying to kind of do this in a sequential, stepwise, and thoughtful manner, fully realizing that there's no data as to which therapy you should do first. This is really where the art of medicine becomes just as important as the science.
Yeah, exactly. Okay, so for those of you guys listening, let's just say this isn't an option for you, right? Like you can't just have 1 or 2 tumors treated. Let's say you've got a little bit more involvement. Maybe you've got a larger tumor, something bigger than a centimeter or 2. And you mentioned some Y90 options and just some other kind of a little bit more than just an ablation or histotripsy treatment. What would be kind of the ideal situation for that patient?
Okay, so let's say we actually I saw somebody follow up 2 days ago. He had a single tumor that was 6 centimeters, so about 2.5 to 3 inches, and a second smaller one next to it. Again, the rest of the liver was fine. It was all in the middle of the liver. And so I didn't want to treat the whole liver. At the same time, the tumor was too big for me to get a successful ablation, because you can imagine if I take a tumor that's the size of a golf ball and I put a tiny needle in the middle, the heat may not go to the edge of that golf ball. And so the Y90 radioembolization is a great option in this case. Similar to the Hepzato procedure, it is done through the artery in the liver. So remember, the artery is the one that carries blood from the heart to the liver. And we infuse tiny radioactive particles. These particles are so small you can't even see them. There are several million of them. And the infusion is completely painless. So we do this under sedation, not under anesthesia. So what we do is we position that catheter in the specific artery that goes towards that tumor to make sure that we're not going somewhere else or even in the rest of the liver. We infuse those tiny radioactive particles. We take the catheter out, put a Band-Aid on you, send you home. That procedure, again, takes about 1 to 2 hours, and it's done under sedation. It is also very well tolerated. There are, again, just like every therapy, there are advantages and disadvantages. So that works extraordinarily well when we're targeted and focal. We can give very high doses of radiation to that tumor, and there's no spread of the radiation elsewhere. The downside comes when we have to treat someone's whole liver. Let's say someone presents with 10 or 12 lesions. Then we have to irradiate the entire liver, and that's where I think we have some challenges and where the Hepzato procedure might be a better option.
Yeah, for sure. Okay, so we've got the Y90. What can you tell us just briefly about LINAC radiation and the IE and the CE procedures? Feel free to touch on either or both of those briefly.
So the LINAC radiation is, I would say right now, it's done again by radiation oncologists. It's still very early in its development and phases. There's no significant or really large-scale data sets right now, so I think we're still learning about it.
Okay,
and that's
good.
probably mostly what I could say. It's still kind of a work in progress.
Okay, so kind of the buzzword for one lobe or for kind of whole lobe or whole liver treatment where you're treating both of the lobes, the buzz conversation in the metastatic community, like we're talking about things like IE and CE, so the immunoembolization for those of you listening, and chemoembolization. How is this different than Hepzato Kit? And what do you think are the risks, the data, maybe the benefits?
Okay. So immunoembolization and chemoembolization are similar to that Y90 where we put that catheter in and instead of infusing radioactive particles, you give chemo-laced particles or immuno-laced particles. I would say 2 things. Number one, compared to, let's say, Hepzato Kit, the efficacy in terms of tumor shrinkage is far lower, and the side effects are far higher. So I think it's really fallen out of favor to do chemoembolization or immunoembolization with the arrival of Hepzato Kit. In our experience, in patients undergoing chemoembolization or immunoembolization, it's not easy to tolerate. You're quite sick for the next several days afterwards, and you have to repeat the procedure time and time again, several times. So what we've always kind of philosophically thought in our field in interventional radiology, which is really why I went into this field, is that I like to see patients go home that day and not be miserable in the hospital. That was kind of what drove me into this. And so when I hear about patients not doing well afterwards or feeling really sick, that kind of disheartened me. So the nice thing about the Hepzato Kit procedure, other than the recovery from the anesthesia, the recovery is actually quite rapid. Same thing with the radioembolization, same thing with thermal ablation. So I foresee that chemoembolization and immunoembolization will probably fall out of favor significantly as Hepzato Kit becomes more widespread use and widely available. Perhaps it might be used in those patients where the Hepzato Kit procedure failed, or patients progressed after it and they didn't have any other options. And so hopefully we really won't see that too often. But I think it's going to be relegated to what I would say the salvage setting.
Okay. We've talked a little about the Y90. We talked about some of these kind of maybe one side of the liver, it really just needs a little more directed treatment. Hepzato Kit, you've said, is a little bit more heavily used right now, at least, when you have a larger amount of tumor involvement or liver involvement. Let's just say I've got 2 or 3 moderate sized tumors. I can see on the imaging and my doctor is telling me, oh, there's kind of this peppering. There's all of these little tiny little specks everywhere that we're pretty sure, just based on how it presents, this is more cancer. And I'm just kind of breaking this down for those of you guys listening, just so that if you're imagining your scans, you can kind of picture what your doctor might be saying. What would this look like as far as why Hepzato might be a better option?
That's actually quite a common occurrence. We see, multiple lesions, but you see a lot of little dots on the MRI. It's always hard to say what those dots are, but we kind of know just historically that those dots are very small tumors in its infancy. So in that case, when we see that, it makes more sense to do a more whole liver or global approach. And that's where I do think the Hepzato Kit plays a role. In fact, the last 2 patients that we did had exactly that appearance. The nice thing is that it really does, when we're infusing the chemo, keep in mind, is a liquid, right? Just like turning on that faucet, running it through that sponge, it'll fill up the whole sponge, so the chemo will fill up the whole liver. So it'll get to all those tiny little dots as well as the big tumors. So that's really the advantage. The second advantage is this. Despite doing a whole liver treatment with the Hepzato Kit, the risk of liver toxicity or liver damage is exceptionally low. In all the patients that we have treated so far, we have measured all their liver enzymes immediately prior to the procedure and then afterwards, and then even 2 weeks afterwards and 1 month afterwards, and not a single person has had elevation of their liver function tests. So it's quite remarkable, almost surprising that we're giving such a high dose of chemo right into their liver, and for whatever reason, the hepatocytes, the normal liver cells, are not reacting to it. And so the liver function remains completely preserved. So what does that mean? That means also that we can give this multiple times if needed. And we can give this with immunotherapy or chemotherapy or tebentafusp, and there's not going to be any significant interaction that we are aware of.
Oh, that's incredible. So it really sounds like there's a lot of benefits to the treatment landscape and just kind of what you guys creatively can do, as doctors, as interventional radiologists. You've got so much more to work with when you can trust that the liver is not going to be compromised.
Yeah, it gives us a lot more. It gives us a lot more latitude in what we can do. And I would say even with this procedure, we're still just starting out. So far, the procedures have gone extremely smoothly. The procedure time ranging from 2.5 hours to 3 hours. Patients all getting discharged either at the end of the day or the next morning. But I actually foresee several technical improvements to the procedure over the next 2 years where we can make it even more efficient as we share and learn our ideas. I'll give you one example. Initially, the procedure was done in the clinical trial where all these catheters and sheaths were left in place in coming out of the body while they were recovering in the ICU. And what we did is, one small adaptation that we did is before they even wake up, we remove them. We use something called a closure device to close the arteries and veins, and then they get a Band-Aid afterwards. So now it's nice that you wake up, you don't have anything sticking out of your body except just an IV in your hand. And so that's just a small technical improvement that we did, and I foresee several improvements that will occur over the next 2 years.
Well, and I think that's the beauty of medicine is when we have modern medicine and it's really been some established care of some kind, like there is so much more room for rapid improvements. And I know you guys as doctors, that's your goal. Like your goal is to make sure patients have as good of an experience as possible and can get back to regular life programming, so to speak.
Yeah, absolutely. And that's something that we always have in the back of our minds. And anytime, let's say I do this or any other procedure, we do a sit-down consultation, either in person or via video, whatever the patient's preference is. And we go over their goals. We go over their needs and their wants, and how aggressive they want to be. And I try to get a very good gauge of their current physical status. In other words, are you sitting on your couch all day? Are you in bed all day? Are you working out? The last person I treated, he was in the gym lifting weights 2 hours a day before the procedure. And fortunately, 2 weeks later, he was back at it. And so we want to get that gauge because I want to return people back to their previous lifestyle.
Yeah, it's just, I know that's something that's so important to me personally, and I hope you guys maybe you can relate that you don't want cancer to take anything more from you than it has to. And so it's so validating, I think, to hear that doctors are understanding that, they're valuing that, and that that we have professionals like you who are looking for how do I make sure my patients have the best quality of life and the most longevity, as they're dealing with metastatic disease.
I would say that's not, Danae, unfortunately, it's not universal. I think, especially in our field, it tends to be much more common. I know I've had family members who have gone through some pretty tough times in terms of their cancer care. And had, I still remember my grandmother who had chemotherapy for breast cancer at 85, and it took a very vital person and basically put her into bed, within weeks, and she really never kind of came out of that. And that was 10 years ago, and that still sticks in my head. And I think not only myself, but I think most in the interventional radiology community, actually most ocular melanoma oncologists I work with feel the same way. We're trying to avoid that. And try to preserve people's quality of life as much as possible. And I think that's, an equal goal in terms of comparing to quantity of life as well. Yeah.
Well, and you mentioned too that this is the kind of treatment that you can have multiple times. So let's just say I've got this presentation of all of these tumors in my liver. It's obviously super concerning. And you're telling me Hepzato Kit's a really good option. So how many treatments could I realistically have, without it producing side effects or things like that?
Okay, so great question. So I think right now we don't truly know, but in general, we're looking at around 6. So what does 6 treatments mean? We do these in groups of 2. So we do one, and then we do another one 6 to 8 weeks later. And then we get imaging afterwards. In general, it tends to be more tolerated with each treatment. As an example, I saw somebody last week in the office after they received their first 2 treatments. Their tumors shrunk considerably. So I sat down with them. I said, look, here are your options. We can either you can continue your immunotherapy. We can get scans every few months. Or I can do rounds 3 and 4 of Hepzato to shrink them even further. It really depends on how you did after the last 2. If you didn't tolerate the last 2, I probably would hold off. If you tolerated the last 2, I'd go for it. He's like, well, the last one I had on a Wednesday. I was back at work Monday morning. I don't really feel any different, so let's just do it. So he's going to get scheduled for rounds 3 and 4 because he's totally up for it. Yeah. There are certain other considerations. We want to make sure that they continue to not have heart disease or develop it. The one main side effect of the Hepzato Kit procedure is that it can lower one of your blood counts. That's called the white blood cell count. So we want to make sure your white blood cell count is within normal range. So sometimes we'll wait another few months to make sure it comes back to normal range. It tends to not be a significant problem. So we want to make sure that you're still safe for the procedure. And I ask them if they're up for it and they want to go ahead.
Okay. Well, I mean, I think that's fair. And I think it's so important that we as patients have the opportunity to be involved in the decision making of like, what do I want? So I think that's a really good thing to fight for, you guys. Okay. So around 6 treatments in groups of 2. And then you mentioned that I could still have my systemic therapy.
Yeah.
So the kind of main options we've got for the systemic therapy are Ipi-Nivo, which is generally for anyone, but we know doesn't have, or historically hasn't had the best response rate as far as I know. And then we also have the HLA-dependent Kimmtrak for anybody who, maybe you're confused about Kimmtrak versus Tebi. They are the same thing. So let's just say I'm HLA positive. I can have Kimmtrak, or I could have Ipi-Nivo. Like, how soon do I have to kind of pause my immunotherapy before I can have one of the Hepzato treatments, or vice versa?
From what we can tell, you don't need to pause it at all. We have treated patients both on Kimmtrak, and we have treated patients both on nivolumab. We've also treated patients on other third-line immuno agents as well. There does not seem to be any cross-reaction in terms of the side effects. And so we have recommended that you do not stop or even temporarily discontinue your systemic therapy. That's kind of the nice thing about this. It doesn't, add to the side effect profile of what you already have. So I don't really foresee any reason to stop your systemic therapy at this time. There is an ongoing trial in Europe called a Chopin trial of Hepzato Kit plus immunotherapy. The results there's some prelim results right now, but they're very, very prelim, and the final results should be out, I would say shortly, perhaps, later this year, which will hopefully confirm the safety of, let's say, Nivo and Ipi with Hepzato Kit. But honestly, I don't foresee any issues.
Okay, awesome. And just for, brief reference, for anybody who's looking for like the data and the studies around Hepzato Kit itself and like the efficacy and how well it works, where could somebody find some of that good data on Hepzato Kit?
So the best data is a recently released trial that was published in the Journal of Surgical Oncology in this past spring. It is called the FOCUS trial, FOCUS, and the first author is Dr. Zager, Zager, who is a surgical oncologist out of Moffitt in Florida. So he was the primary investigator on this multi-center international trial of Hepzato Kit. This is the trial that was presented at a oncology conference in 2023, which then resulted in the FDA approval in the United States.
Oh, that's amazing. Okay, well, we'll make sure that we link that and we'll share that, the FOCUS trial, just so that you guys can see the breakdown, because it's amazing how much stronger of an efficacy the Hepzato Kit shows in the FOCUS trial. So just as we end, Dr. Padia, where do you see the future going for Hepzato Kit now that we're just a year out from FDA approval from last summer?
So I see a couple of things. Number one, in the short term, I see several technical improvements that we can potentially make to make the procedure easier and faster and more adaptable to other institutions as well. One of the things I didn't mention is it does take a good amount of coordination between interventional radiology, anesthesia, and a perfusion team, which handles the filtration of the medication. So a large part of us setting this up at our center at UCLA, we spent about 6 months prepping this between the 3 teams so we could work seamlessly in the room. In the room, for example, there's about 10 to 12 different personnel working on this one patient. And so we want to make sure that everything goes well seamlessly, especially from a communication standpoint. So I think that we can make a lot of improvements in that in terms of the technical know-how and capabilities of the procedure. There's probably some improvements we can make in the filter as well to change or vary how much of the chemo gets withdrawn. We need to further refine the patient population. I would love to figure out in the next 3 to 4 years who it's going to work in and who it's not. Because what I would like to do is see this person in my office before the procedure and say, this is going to work in you. Or even conversely, this is not going to work in you. I want to offer something else. Right now, we kind of offer this in all patients with multifocal tumors throughout their liver. It doesn't work in everyone. And I would love to figure this out as to who it's going to work in, who it's not. In a way similar to tebentafusp, which works in a certain HLA subtype. We know it works in those patients. It does not work in the other HLA subtypes. So if I could figure out a marker or some kind of way to prognosticate people to say that it's going to be a success or it's not going to be a success, I think that's the next option or the next advancement for this therapy.
No, I love that. Well, Dr. Padia, this has been incredible. Thank you so much for joining us today. And those of you who are listening, please make sure to subscribe for our newsletter if you go to our website at cureinsight.org. And just a huge thank you to our sponsors, Castle Biosciences and Delcath Systems, for making this episode possible. Please make sure to just follow along, subscribe, and share this with a friend. And we will see you guys next time.
Thank you so much.